I'm Jacob Lønborg. I'm a cardiologist from Copenhagen University Hospital, Rigshospitalet in Denmark. So before the NOTION-3 trial, there were a lot of unknown issues. One is how is coronary artery disease affecting the long-term outcome in patients with severe aortic stenosis that is treated with TAVI. That is one. The other thing is how will the coronary artery disease affect the patient's symptoms, and is it safe to perform TAVI without revascularization before? So those are some of the key issues in this trial. So in this trial we included patients with severe aortic stenosis that was treated with TAVI, who also had significant coronary artery disease. And we randomized a total of 455 patients to either TAVI alone or TAVI plus PCI. And the primary endpoint of the trial was a composite of all-cause mortality, myocardial infarction, or urgent revascularization. So the key findings for this trial were, the first is that the primary endpoint was significantly reduced with PCI with a hazard ratio of 0.71. And this was mainly driven by a reduction in myocardial infarction, but also a reduction in urgent revascularization. Additionally, we found that performing TAVI with or without PCI seems to be safe in terms of hemodynamic support and the use of inotropics during the procedure. I didn't present that at this meeting, but that's in the paper. The symptom burden. In this trial, nearly 60% of the patients had angina upon occlusion. And this means that the patients that were treated with TAVI alone did not have PCI of tight lesions with angina. And these patients seem still to benefit from the TAVI in terms of symptoms. So if you compare the groups in terms of angina burden or dyspnea 1 month and 12 months after the TAVI, the groups were similar. So this means that the coronary artery disease is somehow an innocent bystander, or not innocent, but it's a bystander. And we probably need to treat it to improve the long-term outcome, but it doesn't really affect the patient's symptoms. I think the take-home message for this is that the PCI in this group is safe. We saw very few complications, and it actually is beneficial because it reduces incidence of myocardial infarction and the need of urgent revascularization. So I think for these patients, the clinical impact should be that PCI in these patients should be the standard of care. But of course we need to consider the individual patient risk, because we also saw an increased risk of bleeding. Yes, as I mentioned, I think it flips the coin a little bit, because during the later years there's been a tendency towards a more conservative approach in terms of performing PCI. And I think this trial shows that one, PCI is safe, and two, PCI is also beneficial in terms of long-term outcome. PCI should be the standard of care, but of course, as I mentioned earlier, we need to make the decision on an individual basis, taking into account the individual patient's risk factor, age, risk of bleeding, complexity of coronary artery disease, etc.